Macular degeneration is a leading cause of vision loss, with 15% of Americans being at risk or already affected. Scientific evidence proves that by using mesozeaxanthin, lutein, and zeaxanthin together replenishes the macular pigment and promotes healthier vision. This formula comes in only one product, MacuHealth.
Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gill, the host of the documentary Open Your Eyes. Please visit the film's website at openyoureyes2020.com, featuring interviews with more than 50 optometrists from around the country, sharing information on eye care and eye disease. Several million Americans have neurologic diseases that affect vision, symptoms ranging from dry eye to double vision to legal blindness. About a third of the brain is devoted to vision, and almost any diffuse disease of the brain is going to affect vision. Devastating neurologic diseases are on the rise. Early diagnosis leads to early treatment and better prognosis. The eyes are not only the window to your health, but the window to the health of our brain. It has been well established that neurologic diseases such as multiple sclerosis, myasthenia gravis, and thyroid eye disease may manifest in the eye and is often initially diagnosed by the eye doctor. Because of advancements of modern technology, eye doctors and researchers will soon be able to fulfill a common goal of using the eye and visual pathway as an early predictor of other common devastating neurologic disorders such as Alzheimer's, CTE, and Parkinson's disease. Today's guest, neuro-ophthalmologist Dr. Alberto Gonzalez, has extensive knowledge on the EyeBrain Connection. His expertise is in sophisticated ocular neurotechnology and is currently the CEO of Olleyes, spelled O-L-L-E-Y-E-S. Dr. Gonzalez-Garcia, or Dr. Gonzalez, thank you for joining me today.
Thank you, Dr. Gill. It is actually a pleasure to be here with you, and it will be my pleasure to share, our modest knowledge about the eye.
Thank you. So explain to our audience, what is a neuro-ophthalmologist?
A neuro-ophthalmologist, it's a subspecialty of ophthalmology, and it's mostly focused on the structure or all the diseases that affect the connection between the eye and the brain. And of course, including the brain itself and the eye. There are several of these, unfortunately, diseases that can affect this kind of patients. And they also focus on the treatment of these diseases. Lately, we have had a tremendous advancement on the treatment of these diseases, especially with the advent of the genetic treatment.
Now, you were trained in Cuba and in the US. What's the difference in training? Is there much of a difference?
There is a difference, obviously. But the difference is basically on the approach to the medicine. And basically because of the lack of technology and the lack of resources, like technical resources, most of the medicine in Cuba falls into the human resources. So that's why they probably formed a lot of doctors, and basically instead of, for example, following a kid every 6 months with a MRI, in Cuba, the doctor will follow the kids every week with their eyes. So it's sort of like a difference in the approach. The other difference is also a little bit on what we call the mother medicine. or the medicine in Cuba is very influenced also by the European currents, while the American is more like Anglo-Saxons, but mostly American model of medicine. But I think the main difference is the technical resources availability.
Now, the eye and the brain, is it the same? How are they connected? How are they related?
That's a very good question. The eye, it's actually, or at least a significant amount of tissues in the eye are part of the central nervous system. So like, for example, the optic nerve and their axons that somehow extend within the eye are part of the central nervous system. So there is a very, very tight and very close relationship between them, like the neurotransmitter in the eyes that are very common in the brain, or the other way around. So that's probably one of the reasons many neurologic diseases manifest also somehow in the eye.
How could we use the eye as a biomarker for neurologic diseases?
That's a very interesting question, Dr. Gelb. Because the eye have a window, the pupil, right? We can have a direct access to most of the structures within the eye, especially the I would say the neuroretinal. And because of that, somehow we can visualize the structure that are similar to the brain. So for that reason, we can use the direct structural analysis of brain-like structures. Like, for example, if you do a tomography of the eye, we can do some sort of like a live biopsy of neural tissues, right? Like the optical coherence tomography does. And that allows us to have a direct access to neurons that can be affected on the same way they will be affected in the brain. Like Alzheimer is a good example of. We already have evidence that Alzheimer that not only affects the brain, but can affect those neurons within the eye. So there is a common pathway in the pathologic effect that also express within the eye.
So the neuro-ophthalmologist is almost like the dumping ground for all other eye doctors. When the other eye doctors don't know what's wrong with the patient, they send them to the neuro-ophthalmologist. So you have to be an expert not only in eyes, but you have to be an expert in the whole body and in medicine. And what is it like to have to see all those very difficult patients?
I think I should make a disclosure before we continue. Since I arrived to US, I've been full-time dedicated to the industry and the development of new technology for the eye care. But one of my professor in Tufts University, he used to say, the neuro-ophthalmologist is the only doctor that can say, I don't know. Because the whole change finished there, right? But basically what he was trying to describe what you just said, right? When a disease is not evident in the eye, when all the eye doctors cannot confirm an eye or a nosocomial issue within the eye, then they they suspect that the issue with the vision might be behind it. In other words, in the optic nerve or somewhere else in the visual pathway. And that's the reason when they don't find an explanation for a vision loss, they refer those patients to the neuro-ophthalmologist or the neuro-optometrist for the evaluation of those patients.
That brings us to the next question, because in neuro-ophthalmology or neuro-optometry, we use the MRI and the MRA a lot. If you could explain to the audience what's the difference and why we would use those as an adjunct to help us in neuro-optometry or ophthalmology.
There are several techniques for the imaging of the brain or optic nerve structure that start with a CT scan, for example, which is basically a bunch of X-ray, right? The group of magnetic resonance imaging or angiographies, or even the functional modalities of it, different from the CT scan. What they do is they create a magnetic field, and they shift those magnetic field in a way that whenever there is a change in those structures, it can be imaged. The difference also is that when you are using modalities like the CT scan, it is much better for hard structures like the bones or other areas with different density in the tissue. The MRI is better for soft tissues like brain itself, right? And that's why most of the I would say neuro doctors, they prefer the MRI over the CT scan, although the CT scan is very good for other specific pathologies. And within the MRI, then you can use contrast to enhance given structures within the eye, or you can focus on those tissues that are moving, like the blood vessel, like not the blood vessel, but actually the blood, I would say, flow. So because of that, because those are moving, part of the body, then you can enhance that with those techniques.
There are certain number of medications that actually could affect the eye, from statins to medications like Viagra, the ED medications. Can you explain how they could affect the nerve of the eye and some of the side effects?
To be honest, we know that, like you well said, there are many drugs that can affect the eye: hydroxychloroquine, tamoxifen, sildenafil, like you said. It is not really well understood the way it happened, but there is evidence, of course, that linked those drugs with specific, affections within the eye. In the case of the sildenafil, it's still controversial, but most people believe that if there is some kind of predisposition in the eye, especially in the optic nerve, it can lead to ischemic disorders within the eye. Or the hydroxychloroquine, once you use it for long periods of time, or at a high dose, or if you have any other issues in the body that predispose to the accumulation of the drug, then you can have some level of toxicity within the retina, especially in the outer layers of the retina. So every drug affects differently and different structures of the eye, but we're still learning. We're still learning on how to use it. But fortunately, we already, and this is part also of the drug production. So when manufacturers are coming up with new drugs, they are enforced by the FDA to do toxicity tests. And that allows to understand when you use those drugs, where is the probability, what is that probability, and what is the dose that will put the patient at a greater risk for this kind of affections.
And statins have had some side effects of double vision or ptosis, which is an eyelid droop. If they go off the statin, does that typically go away?
It could until certain point. Fortunately, it's not that frequent. So if we look into the massive amount of people that use statin, it is not that it's not an effect that occurs very, very frequently. Also, the new criteria of the Cardiology Society in US, some sort of like decrease the intake of this medication. For example, right now we know that cholesterol is not directly related to ischemic disease. Only if you have high cholesterol plus some history of family history of ischemic diseases, then is when the doctor will put you probably under a statin drugs. But if you have just high cholesterol, very likely, unless you have any other risk or risk factor, very likely the doctor won't put directly on statins.
There are a couple of very common symptom or presentations that are referred to the neuro-ophthalmologist. One of the most common ones is double vision, or what we call diplopia. What is the workup? What are we looking for as a neuro-ophthalmologist for someone who has double vision?
Okay, when you are evaluating a patient with double vision, the first step is confirming, of course, that there is such a double vision, and there is an examination procedures that allow the doctor to understand, not only to confirm that the patient has double vision, but also to understand, which is probably the second step of it, whether is a monocular double vision or a binocular double vision. And what it means is that there are certain diseases in the retina, and even if you patch one eye, you might still see double. Or what we also call, that double vision can be also confused with what we call metamorphopsis, but we need to be very careful, right? But if it is monocular, that already discard or rule out already a huge list of possible diseases, right? Now the doctor can focus on those diseases within the retina that can cause diplopia or diplopia. If we confirm that the diplopia is bilateral, so it's binocular diplopia, then very likely it's because the normal parallelism of the eye, it's broken, right? It is not working properly. The next question is it something congenital, or this is something new, or what we call also acquired? If it is congenital, then very likely it's because of congenital strabism, and very likely it's not a reason why a person would go to a doctor. It's something already not. So very likely something acquired, and within the acquired, depending on the age, right, then you can start looking for different diseases. If the person has 70-year-old, then very likely it's an ischemic issue. Then you will have to look into whether it's an ischemic of the nerve itself that control the movement, or is an ischemic within the nucleus in the brain that control all the movement. If it is more like a young individual, then you have to for sure rule out first tumors, then you go into infections, inflammation, and other causes of diplopia. So that's somehow, like, very briefly, of course, of the workout. And then, of course, like you will say, if there is no obvious cause for the diplopia, then the doctor will indicate all this imaging modality that you previously mentioned, MRI or CT scan, to confirm or rule out the ischemic tumors, or what we also call compressive syndromes, that can lead to the affection of the parallelism. It's very important to also understand that that position of the two eyes, in order to have both looking into a single point in the field, is controlled by many, nerves, right? And each of these nerves can also be linked to specific disease, like a person with 70-year-old or 80-year-old with a sixth nerve palsy very likely is an ischemic disease. But if it is a fourth nerve and a young person, then we have to more incline to other causes. So it depends on all this data that you are collecting. Since the interrogatory, it can lead to specific cause and help you to rule out all the group of them.
Explain what is sixth nerve palsy, what the word palsy means, or fourth nerve
Oh,
palsy.
sorry. Yeah. The eye is controlled by three, or the movement controlled by three main nerves, right? Third, fourth, and sixth. And the sixth nerve, it's basically, so there are 12 pair of what we call cranial nerve, right? And of those, the six control basically the order or the muscle that make us move, in horizontal way, let's call it this way. So when there is a sixth nerve palsy, then the eye tend to inward and then create all those kind of, diplopia issue. It is because of the way it is structured, because of the position of the nucleus that control that nerve, then it is somehow more common or more predisposed for this ischemic events when you are a little bit, getting into the age like we are.
So if you're a 7-year-old patient and you're diabetic and all of a sudden you're seeing double, most likely it's from ischemia, not from a tumor. But if you're a younger person and all of a sudden you're seeing double, it's more likely it could be a tumor, God forbid, an aneurysm or something like that.
Correct. Exactly. So there are those, little details that since the person is walking into the office, that you already start thinking about it and help you be more efficient, right? And more expedite in your diagnosis.
Vision Edge gives you less eye strain and reduced damage caused by blue light. We like to call Vision Edge sunscreen for the eye. It all starts with your highest level of visual performance, only achievable through scientifically proven Vision Edge.
Thank you for tuning in to the Open Your Eyes podcast. If you like the video you're watching, please hit the like button. Also, hit subscribe for weekly new episodes of the podcast, along with pod winks and bonus content. All right, let's get back to the show.
Let's talk about the person who has lost their vision and it's unexplained. They've already been to 4 doctors and now they're in the neuro-ophthalmologist. How are we going to work them up from a neuro point of view?
That's okay. You know what? The first step is a good refraction. It might not be, I'm not so sure in the US, but I remember having many, many cases that they were referred for, bad vision, especially in one eye. And once they fall into the hands of a very good optometrist, it was 20/20 of vision. There was never a actual loss of vision. So I think we should never assume that there is such a loss of vision. We have to, a good neuro-optometrist or a neuro-ophthalmologist should start from the beginning, always, because sometimes this kind of things happen. The next step is a thorough, examination of the eye and understanding where the actual signs of diseases that can affect the vision. For example, when the patient has inherited retinal diseases, it's very common that they start with very, very subtle signs that most doctors are not looked into it, like a little paleness of the optic nerve, of the blood vessel that are thinner, or there is a grayish, colorage in the red, that famous red, right? Those kind of little things already, make you feel that, oh, there might be some inherited retinal diseases here that we should focus on. The other gender, right? Monocular, painful, lot of vision. You have to, female, you have to rule out, of course, multiple sclerosis or ophthalmitis. As you know, ophthalmitis can be anterior, posterior. If it is anterior, then it's obvious. Very likely, every doctor will understand that, but unfortunately, that is only 10% of the cases. Most of the cases are posterior ophthalmitis. So you have to fall into other then ancillary tests like electrophysiology or a very good perimetry technique to understand whether is such an affection. Then, of course, you must send some imaging like MRI or even depending on your expertise, you can go directly to a spinal tab to see if there is, some clonal signs of the immunologic disorder. So those form like what is famously called the McDonald, criteria. So with clinic, imaging, and cerebrospinal fluid, data, and then you can make the diagnosis. Or of course, if there is any, tumors in, or if any, ischemic event of the brain. So the list is really huge, right? But data, like since the patient is coming into the office and you already know whether it's a young or old person, already automatically make you focus on a given group of diseases. There's always some, exception, but most of the time, you following the rules can make a diagnosis of these kind of diseases.
Let's talk about a common neuro patient that we see, comes in, loses their vision for 15 to 20 minutes, sometimes gets a headache, sometimes doesn't. We'll see scintillating on the side. That's a very common complaint of patients. Probably we see one of those 2 a week. If you could talk about retinal vasospasm, retinal migraine, and and just tell us a little bit why this happens.
That's what we call the fugax, right? Or ephemeris loss of vision. And when you have a patient with those temporary loss of vision, also you want to organize yourself of how much it lasts. it'll last only a few seconds, or it'll last minutes, or it'll last hours. So depending on that, then you can, direct that. If it is like a very, ephemeris, it could be just a, common flashes. Maybe there's a traction in the retina that is creating those symptoms. Or if it lasts a little bit more, like the one you described, it could be sort of like a spastic disorder of the blood vessels, which are most of the time linked to what you just said, to migraines. And this is another example of how the two organs, right, like the brain and the eye, are so much related to each other that they share the same symptoms. So even if you have a migraine, and the migraine affects the occipital lobe, then you might have even a temporal hemianopia, or you can have a quadrantanopia, or you can.
Explain what that is.
Oh, sorry. So if the brain, if the part of the brain that is affected by the migraine, which is basically a vascular disorder, right? It's somehow there is a dysregulation of the normal contraction dilation of the blood vessels, that creates a temporal, I would say, changes in the functionalities of the neurons. It might start triggering in a way that it creates a very bright stimulus that most of the time it migrates. You start in a little section of the retina, and I start moving up, but sometimes actually it just shut it down, the neurons, and create an actual what we call hemianopia, which is basically that in your field of vision, and by field of vision is all the area that we can see with a steady eye fixating in a point, right? So if one part of this, most of the time, half of that field of vision turns black or turns brilliant, turns just one quadrant. So depending on the area that is affected, you might temporarily lose the vision on those centers. Most of the time is a very benign condition that, and benign, I mean, if you don't take into account how debilitating can be in some patients, but most of the time is benign, painful, temporary loss of vision that requires a neurologic treatment, right? That can go from regular pill to injections, right? But it is very important that every time a patient have these kind of symptoms, go to a doctor. Regardless whether they go to a neuro-ophthalmologist, a neuro-ophthalmologist, or a neurologist, it's very important to go to a doctor, because sometimes those can turn into permanent defects, and there might be preventable if you go on time to your doctors.
What are some of the triggers of a retinal migraine, as far as foods go or stress?
Yeah, there are so many, Dr. Gal. It's amazing the amount of things. It could be noise stimulus. It can be a visual stimulus. It can be stress, like you said. Like most of the time, one of the most common is the deprivation of sleep. If you don't sleep the times that you need, like 8 hours a day or more, then it might trigger. Or it can be as interesting, like a Chinese, kind of a spice. There's there's actually a migraine that is called Chinese restaurant migraine, because the migraine is triggered by one specific spicy use on this kind of restaurant. And I'm not trying to be, I love Chinese food, but it is what it is. So there is a personal predisposition to specific triggers, right? Like what you said, that on myself, it could be sleep deprivation, on other people can be food. So it varies patient to patient.
And with ophthalmic migraines or ophthalmic vasospasm, it could last between 15 to 25 minutes. It could be one eye or it could be both eyes.
Correct. If it is
part of the vision.
Correct, you are totally right. The most common is and this is very important when the patient has the kind of symptoms, they want to patch one eye, because most of the time the patient sees as one eye, but it's not one eye. It's just that it affects one half of the field. And the patient might confuse that as one eye issue, while it is actually the brain, the one that is being affected and not the eye. But that's totally right, yeah.
And I just want to make sure that people understand that if this happens not for 15 minutes, but it only happens for seconds or 1 minute or 5 minutes, it's very different. And if you could explain again the difference, because one could be an impending stroke, or one could be possibly a tumor and causing the nerve to be swollen, or side effect to medication. So if you could go into that in a little bit of clarity.
Sure. For example, it could be multiple sclerosis. Like if you're doing, you might be doing exercise, and if you have, for example, multiple sclerosis, and the temperature of the body increases for a given time, you might have blurry vision. And when you stop your exercise, that might go away, right? That could be a sign of multiple sclerosis. And basically what happened is that you have a latent inflammation of the optic nerve, but when the temperature raises, then it starts to affect mostly the nerve. It could be that you are, let's say, constipated, and the sudden increase so when you increase the pressure, the abdominal pressure, that in turns increase the pressure within the skull, right? And that pressure within your head can trigger a loss of vision because of the present. Normally it wouldn't, right? But if you have, let's say, a tumor, and that tumor is very close to any visual pathway, any displace, right? Any change in position can start temporarily affecting the vision. If you have like common, you are let's say, a juvenile, you have, let's say, 13-year-old female in your metabolic, coming through a lot of metabolic change, you're a little bit overweight, and then you sneeze and you have a blackout, right? That could be because you have benign high intracranial pressure. So there are many, 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 many reasons why you may have, and depending how you describe it, that's why it's very important that the patient know himself and be very detailed. The more details they can provide to the doctor, the easier will be to come up with a diagnosis.
Let's talk about eye movements. How can we diagnose some systemic disease based on poor or irregular eye movements?
You previously mentioned probably one of the most common one, which is diabetes. Diabetes is a systemic disease, like you know, that can affect most of the target of the diabetes of the blood vessels, right? And blood vessels are everywhere, including those nerves that control the movement of the eye. So when you have diabetes, you are at risk to develop this kind of affection of the nerves that affect the or that are in charge of the eye movement. If you have loss of vision for, many other diseases, right? You might end up with what we call nystagm, right? And the nystagm will create some sort of constant movement of the eye. And depending on the direction, whether horizontal or bilateral, that can also let the doctor know whether it's a congenital nystagm or is an nystagm can be related to, other affections of the brain, or it can be something that it is just related to the low vision, like, for example, you can see on albinism, right? So there are...
That's a shaking of the eye, nystagmus.
Correct. Yeah, that's correct. Thank you. When the eye, it's basically, it's a resultant of a continuous, the eye is constantly seeking for something to fixate, right? And when the vision, and I'm trying to explain this in layman words, when the vision is very low, then the eye doesn't find that fixation, is constantly, creating this kind of shaking of the eye.
And thyroid eye disease could affect the eye movements and the way the eye and the lid are together. Can you explain that a little?
Correct. The thyroid related eye disease or orbital disease, there are many names actually from Graves. That was, Graves was one of the first, or probably, one of the first who described the disease. Basically is an autoimmune disorder. And what it is that the body creates an antibody, right? Which we normally have it to fight infections or to fight any foreign tissue or foreign body within the eye, right? Within the body. Well, the problem here is that those antibodies, when they look at the tissues of the thyroid and the tissues within the orbit, they recognize those tissues as a foreign and then as a strange, and they start fighting those tissues. So it's not that the thyroid affects the eye, is that there is a common basic disease that affects both at the same time, or asynchronous, or only one of the other. So not necessarily they have to happen always at the same time. And basically there's an overexpression, inflammation within the tissues of the orbit that could be two main. First is the fat within the orbit, so the bone structure where the eyes, the house of the eyes, right? Or actually the muscles that controls the eyes of the movement of the eyes. When that inflammations happen, it start to growing and growing and growing. And because the bone is a rigid case, then the only way the eyes has to, to alleviate the pressure is moving forward. And that's what we call exostalus, right? When the eye pops up, and also because there's a muscle that control, right, the movement of the lid, you can either have retraction of that, or at some point you can go into ptosis. But the most common is, of course, the retraction. But at some point of the inflammation, those muscles, those movement of the eyes are compromised. Now, specifically on the thyroid orbitopathy or Graves orbitopathy, the way we want to call it, even though the movement of the eyes are compromised, they don't usually create diplopia. Only when they have in a very advanced disease is when they create diplopia. And this is probably one of the reasons sometimes this patient comes to you late, because they don't feel it's just a change on, oh, my eyes are a little bit bulky, or they feel dry eye because now during the night the eye doesn't close perfectly, and then there's a dryness of the eye, and they have keratitis or corneal ulcer or other. Most of the time, those patients come for a complication of the actual disease and not because of the direct symptoms of the disease.
And diplopia, again, is double vision. Keratitis is an irritation, like a scratchiness on the front surface of the eye, the cornea, where you have little sores on the front surface of the cornea. And this is similar, this autoimmune process is similar to myasthenia gravis that can manifest in the eye.
That is correct. In this case, is what you describe. It's the opposite, that the eye tends to close and close and close and close, and is because of the, an immune disorder of the muscles, in this case, the muscle of the eye. But it affects all the muscles in your body. Depending on the patient, sometimes the eyes are the first symptom, the drop of the, of the lid, or ptosis that we call, right? Sometimes it's a breathing difficulty. So depending on the specific patients, they might have different symptoms. And there are different techniques within the office that the doctor will have to understand whether it's a myasthenia-like, ptosis, or is actually a ptosis for any other kind of disease.
So let's turn our attention to tics. It's very common for a parent to bring a young child in because they're blinking like this, and they can't stop with a blepharospasm. What is that typically indicative of?
Most of the time, it's just a what do you call maniac? It's not maniac. It's a you will have to help me on the term in English, because it's sort of like just the kid tend to do it because it's a stress, or because not because of an organic problem within the eyes or within the brain of the person. Most of the time, it's just a stressful condition, and they tend to have this kind of movement, sometimes involuntary movement of the eye. This kind of tics, depending on also the frequency and the amplitude of the contraction, then we can sort of classify. Like some of them, the most common are the myochemias, right? Where there's a little tics. It's a very high frequency, right? And that very high frequency could be just a neurologic, muscle condition, could be toxic, could be an expression of a toxicity of a medication being used, or it could be a much deeper neurologic condition that the person can have. Another, it could be also a sign of epilepsy. Some kids might, start with this kind of movement of the eye, and when you start looking into the electroencephalogram, then you notice that there's actually a part of the brain that is creating the discharge of the muscles. So really many diseases can cause this kind of tics, but most of the time it's just related to stress that we can you consult the fathers. Sometimes the kids are on a stressful condition within the school, either the test, or they're being bullied, or any other let's say psychological conditions that can lead to it.
So I want to distinguish that from an adult who gets the flickering of the eyelid, like you said before, the myokymia. And I know sometimes this lack of magnesium, typically people will
dehydration.
It'll stress, or typically, what do you recommend for that?
It depends on the cause of that. If it is like patients that, dehydrated or they have metabolic issue, you have to suggest to use like nutraceuticals, to use some kind of medication that can help supplement, like for example, if it is a potassium or a magnesium deficit, then you will like to use all those kind of, medication that can help do it. Sometimes it is not something you can fix with medication, because you have what we call blepharospasm, and you will have to, inject some medications that can somehow inhibit the connection between the nerves and the muscle itself.
Since I bought Safe for You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe for You products. I like to bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe for You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe for You.
And most importantly, the reason why I buy Safe for You is because it's safe for me and you.